Good afternoon, everyone. This is Julie Cox-Sid. Thank you so much for joining Dr. Cox and I this afternoon with this first of our new conception of ideas. The idea was just to have short little sessions, maybe 10 to 20 minutes. This one may go a little longer because it's an exciting one, but we're going to see how this works. There are handouts of all the slides because I know everyone asked for all the references, so those are there to download. And I hope that you enjoy this today. I'm going to turn this over to Dr. Cox and let you talk about myelomalacia.
Thank you for studying with me today. We will be studying myelomalacia. When we look at an x-ray like this, we really don't know anything. At least we miss a lot. We see degenerative disc disease, but what's really going on within the interstices of that vertebral canal? What is spinal stenosis? It's a narrowing of any natural body orifice, but if you and I as a clinician, we know that it can be due to a combination of disc degeneration, end plate hypertrophy, facet arthrosis, ligamentum flavum thickening, disc herniation, synovial cyst, discal cyst, Tarlov cyst, other pathologies, anything that narrows down the central, lateral, or extraforaminal canal. When we look at this paper, we see that cervical spondylotic myelopathy has become the most common cause of spinal cord dysfunction. That means that we as chiropractors are going to be called upon with the increasing frequency to look at and treat this condition. When we look at this case, I consult with a doctor in Honduras on this. It's a 76-year-old man who underwent a 2-level discectomy in mid-December 2019. He felt better afterward for lower extremity pain. However, 2 months later, he's quadriplegic. Reflexes, all 4 limbs, 40% normal. He woke up 2 months after the lumbar surgery, quadriplegic. The neurosurgeons have further depressed him by saying that cervical surgery, he would not make it through it. When I look at this case, here's the lumbar spine. We certainly see spinal stenosis at 3, 4, 4, 5, 5, 1. This was what the original surgery was. Facet arthrosis, ligamentum flavum thickening, marked stenosis. This lumbar spine was surgically treated, relief in December 2019. 2 months later, he is quadriplegic. And we look at the cervical spine, we see marked stenosis here of a Kang type 3, which we'll learn later. Disc herniation, and this patient will not undergo any more surgery because the surgeons say that they don't believe he would make it through it. So when you have tandem surgery, the message here is and you know that 67% of people, whatever we see in the lumbar spine, we're going to see it in the cervical spine or vice versa. So you and I are going to be treating tandem stenosis. When this is the case, as in this one, whenever you have lower extremity radicular component, but lumbar spine stenosis, tandem cervical stenosis, do the surgery if you're going to do it on the cervical spine first. If lumbar stenosis was treated first, a dramatic exacerbation of the symptoms related to the cervical stenosis can occur soon. So you do cervical decompression first. It's known that having a severe history is more prone to having a poor prognosis. But this statistic for you and for me, doctor, is quite meaningful. This is Monomoir et al., just published 3 years ago, that by year 2025, 59% of people over 65 will have spinal stenosis. You and I are going to be inundated with these patients, and we better be ready for the diagnosis, the conservative chiropractic care, the interdisciplinary neurological and surgical care that some of these people will demand. Fang wrote here, in treating intervertebral disc herniation, a 5-year study published this year in May, that in treating 75 people with lumbar disc herniation showed that the volume of the protrusion decreased by about 46%. It was obviously absorbed in 24 cases, partially in 26 cases, not absorbed in 19 cases, and actually increased in size in 2 cases. These are all shown by the Japanese Orthopedic Association scoring, and it just shows that the treatment, non-surgical treatment of ruptured lumbar disc can be very effective. Those who it is not effective on or show progressive neurological deficit are surgical cases. And what percent are these? Well, if you look at the study by Adagwa of about 500,000 cases, and that of another author, the combination of these showed that 0.8 in one study and 2.5 million people in another showed that 1% of 3 million patients underwent surgery. So if you take that 1% out of the equation, non-surgical care is going to be treated by chiropractors and other non-surgical entities. And we know that chiropractors are seeing up to 50% of these people with spinal stenosis. Sharma wrote that and this is very interesting, that the main surgical indication should be pain, not motor weakness. Motor weakness reported in 30 to 50% of the patients with disc herniation. To me, that means you and I must carefully neurologically follow these people with lumbar spine stenosis and neural component, so that if there is progressive weakness, if there are cardiac signs, if there is a non-dermatomal distribution of pain, that we ask for neurological, we ask for MRI, and today even looking for imaging of digital tensor imaging to find the levels of apparent diffusion coefficient change and anisotropy change. Here's a paper about the referral patterns for surgical consult with foot drop. This was just done in the journal Manual Manipulative Therapy in June this year. They asked physical therapists if they saw a foot drop, 34 to 61% were likely to refer for immediate neurosurgical consult. That means some didn't. If you see motor weakness, you follow it very closely. There are papers showing that the return of motor function can be best non-surgically treated than surgically. And then you and I see many of these people post-surgically who have what? Still motor weakness, post-surgical continued pain. Here, Core says that that good conservative care, avoiding surgery, can reduce the chance of functional, avoiding operation on patients with less than 50% chance of functional improvement can reduce current surgical volume by 63%. A call for you and I from April of this year in Spine Journal to do the best job that we can. And what is our outcome? Well, here, this author in Complementary Therapies in Medicine last year said that an RCT of 150 people with low back pain treated with Cox flexion distraction showed improvement at least 50% in pain and 56% in disability, where high velocity, low amplitude gave 8% relief. Why is that? It's because many people, as they age and develop spinal stenosis, do not do well with high velocity manipulation, and we turn to what? Distraction, mobilizing manipulation instead. This paper showed FD better results in low back function than high velocity. The number to treat was 2. What does that mean? For every 2 treated, 1 was benefited. And what is benefit? Minimal clinical improvement has been defined as 30% improvement, then 20% improvement, and yes, shortly will be defined as 10% improvement. Here's Kwan. He wrote about the 4-week effect of Cox distraction manipulation with therapeutic treatment of L4, 15 people with L4-5 herniated discs. They found that Cox distraction manipulation combined with therapeutic modalities appears to be safe and efficacious. Non-invasive treated for people with L4-5 herniated disc. I share these with you so that you see, as opposed to some recent papers I've seen that don't think we should treat spinal stenosis, disc herniation, free fragments. And yet these are the cases that respond very well to our care. O wrote here in the Journal of Physical Therapy Science last year that flexion distraction and drop technique may serve as effective interventions for the straight leg raising angle of intervertebral disc height in people with disc herniations in the lumbar spine. This paper has talked about oscillating versus steady distraction. This paper just came out in the Journal of Back and Musculoskeletal Rehabilitation. The effect of oscillatory mobilization as compared to sustained stretch mobilization, oscillatory is superior. Why? It creates the hysteresis and the creep to stimulate circulation into the disc. And what did Beate and Wong say? They said for a successful manipulation, you must have imbibition of fluid through the end plate from the cancellous vertebral bone into the intervertebral disc. Cervical spondylotic myelopathy. The most common cause of spinal cord impairment and increasing in frequency. The hallmark symptoms are clumsy hands, loss of hand dexterity, balance issues, gait instability, sensory and motor dysfunction. So patients with cervical spondylotic myelopathy are divided into mild, moderate, and severe. The literature will show that conservative care is good for mild to moderate. You get moderate to severe surgical cases, meaning that you and I, as chiropractic physicians, must be capable of interdisciplinary care. Yes, you must have a neurologist, a neurosurgeon, an orthopedic surgeon if you prefer, at your beck and interdisciplinary call in handling some of these myelopathy cases. Keep in mind the new phenomenon of Kegan's cervical spondylosis. That means that in cervical spondylotic myelopathy, we have weakness, instability, asymmetrical muscle atrophy, loss of deep tendon reflexes in the lower extremity. It is due to the funicular compression of the lateral spinal thalamic tracts in the cervical spine due to cervical degenerative myelopathy. This is now called Kegan's cervical spondylosis. Many of you have seen this. If you were like me, sometimes it puzzled me before I read these studies as to how cervical spondylopathy results in lower extremity partial paralytic findings that you and I see. Kegan's cervical spondylosis. We also have to remember about subacute degeneration of the spinal cord combined. Remember, it's due to vitamin B deficiency. So you and I see Kegan's spondylosis, cervical spondylosis, and the MRI doesn't look, it may be a Kang 1 to 2. If this is the case, we look for what? The deficiency of methylcobalamin, vitamin B12, the failure of converting homocysteine into methionine, the use of vitamin B6, 9, 11, and 12 in order to ensure that the more prevalent vitamin B12 deficiency causing subacute combined degeneration of the spinal cord is not present. Can I share this with you? As a clinician, when I saw lower extremity or upper extremity radicular component with motor, sensory, and reflex change, or even without, I always put them on two formulas. One of them is vitamin B that has cobalamin, folic acid, or folate, because folate, methylene tetrahydrofolate, is much quicker to act and assist in treating subacute combined degeneration of the cord, and chondroitin sulfate, which is known. And if you notice today, the paper's talking about not just anti-inflammation, yes, using the word what? Regeneration of white fibrocartilage. So you have to be aware of the deficiencies of things like B12, copper, in the cause of cervical myelopathy and lumbar myelopathy cases. I'd like to just share with you the new Kang classification, because we're using it more and more, grade 0 through 3. This is there for you looking. Here's a Kang grade 0, no disc herniation, no cord edema, no contact of the subarachnoid or cord. Kang grade 1, you see small disc herniations that do contact the subarachnoid space, but it does not exceed 50% of that space, as opposed to grade 2, in which we see that the disc herniation, the stenotic element, not only contacts the subarachnoid cerebrospinal fluid, but also compresses into the spinal cord, but shows no what? Edematous, myelomalacia, aseptic necrosis changes, as opposed to Kang 3, which here shows marked compression into the cord and edema as hyperintensity within the spinal cord. Kang. These are quite accurate, and that you get that paper, you'll see the accuracy of this. I'd like to introduce you to Kobayashi. This gives you and me an opportunity to quiz the patient and come up with a subjective evaluation questionnaire to diagnose lumbar spine stenosis and the quality of life the person is living. This is from the Japanese Orthopedic Association. You'll note, and you can read these, the 10 questions. For example, numbness is present in both legs. When you add up these scores, if you come up with a total score of 4 on questions 1 to 4, or a score of greater than 1 on questions 1 to 4, and greater than 2 on questions 5 to 10, indicates the presence of lumbar spine stenosis. An excellent vehicle to give to the patient when you first see them to determine the presence of what? Lumbar spine stenosis. This is the Japanese Association's scoring that I give to you. Here is the Nurek classification of degenerative myelopathy from grade 0 through 6. And there they are for you. Let's look at a case. A 61-year-old female seen for acute numbness, pins and needles of both hands, the left worse, pain of 10, cannot write or sleep, has balance issues. Do you see balance issues in your people? So prevalent are falls and balance taking place with spinal stenosis that presently there is a study going on directed by Kurt Olding with the Miami University of Ohio and the Parker College of Chiropractic to determine the effect of flexion extraction manipulation on aiding people with balance. Do you find this to be a problem in your patients? I tell you, I find it to be a problem in myself at age 80. Okay, so I'm very interested in that. Well, this lady, this pain started after surgery for carpal tunnel syndrome and hip surgery. Total of 6 times she had surgeries. She has left foot drop following back surgery. No help from chiropractic or PT. Grip strength 31 in the left, 55 in the right hand. Here is the sagittal MRI, advanced C4-5, 5-6. Clear down here at 7-1 with cord edema. Okay, note the effect of myelomalacia at the C4-5 levels, always the tension getting. Here on the axial view, certainly we see a marked right-sided stenosis in this patient. She also has central stenosis and lateral foraminal stenosis at 3, 4, and 5 levels. In the lumbar spine, same thing. We see degeneration at these levels. We see ligamentum flavum thickening, disc herniation, spinal stenosis, degenerative spondylolisthesis, all equating to what? Lumbar spinal stenosis with marked ligamentum flavum thickening. Why are they black? Because of calcification within the ligamentum flavum and even into the faucet hyaline cartilage. So the stenosis is advanced. Also note multifidus atrophy as seen. Remember that the multifidus inserts into what? The interspinous ligament and the synovial lining of the faucet joint. Think about when we distract the spine, what we are doing to the circulation within the facet joint. What if you have a synovial cyst? And as Wolbe pointed out, the 12 millimeter cloaca is plugged and can't drain. Are we getting a hysteresis, creep effect when we distract with oscillatory mobilization to aid spinal stenosis as we see here? So the treatment plan in this patient was protocol 1, foramen magnum pump. Those of you who study with me in didactic and are instructors through National University of Health Science know that we use the foramen magnum pump to begin and end spinal manipulation. We couple foramen magnum pump with galvanic tetanizing current, treating trigger points, dry needling if you like, in both arms. We use the Disc-Gap Plus. I take 4 of these a day myself. We use it at 3, enhanced at 3 a.m. and 3 in the p.m. with vitamin D, E, and vitamins B, 12, 11, 9, and 6. This patient with a total of 13 visits results in acupuncture at the 7th visit with an occipital restraint, applying foramen magnum pump, as you see in our didactic presentations. Started on the 5th visit. On the 8th visit, the patient felt her first relief. On the 9th visit, we started protocol 2 as she had showed good clinical relief. Acupressure with FD really changed the treatment success. We, on 7/18 here at about 8 visits, hands felt better, a drop of pain from a 10 to a 4. We were still applying our treatment in the low back with an L3 restraint for the L4 degenerative spondylolisthesis with tetanizing current from the L4 to the left anterior tibialis common peroneal nerve. 4 visits here in July with occipital restraint, acupuncture, VAS pain of 5 for the neck and the arms. From 10, she writes well, hands are stronger. Low back pain is a 4 with the treatment of L4 degenerative spondylolisthesis. So this has been a whirlwind. How long did I take?
Oh, about 22 minutes.
22 minutes.
Pretty good.
Sorry if I took too long for you, but doctor, you're going to be seeing these. If I can make a couple of observations with you, and you don't have to agree with me, you can say, Jim, you're all wrong. But I predict, and the literature documents it, that you are going to be seeing more and more degenerative spondylolisthesis and myelopathy of the cervical, the thoracic, and the lumbar spine. I can't lumbar roll these people. Not that there's anything wrong with a lumbar roll, but it is when do you apply it? I offer to you that flexion distraction, what we've dubbed Cox technique while I'm alive, is very beneficial. If you think that there's any benefit to it, if you think that increasing disc space, increasing foramen area by 28%, dropping intradiscal pressures from a positive 25 to a negative 192 to create a centripetal force to pull back nuclear material, if you feel that afferentation, stimulation of mechanoreceptors 1, 2, and 3 by the lateral spinal thalamic tracts carrying to the somatosensory cortex, stimulating the production of endorphins, serotonin, and dopamine, carrying back down the corticospinal tracts to relieve pain. If you think that restoring full physiological range of motion to the best of that patient's ability, if you feel that that's effective, then I would love to study further with you. Julie, so
Yep.
I'm done.
All right, just want you to know if you want to study more on myelopathy, you can do this online. We have 140 plus things on there. So 2 of them specifically on myelopathy. And we have hands-on workshops. The interdisciplinary conference we just finished a couple weeks ago. I'm waiting on the recording to be here. I'll load that to the website. Last year's 2019 is already up online at our learning management system. So you can study, get CE credits for studying with us. And we are attempting to do live courses. We've canceled a lot, but we're looking forward to some this fall and hope that you can join us. Next year, you'll see we are introducing 2 new parts. Instead of doing an honors course or interdisciplinary, we're adding one course on thoracic spine and adjusting and research, and you won't believe everything that we've gathered there. And then the next one, part 5, will be on extremity adjusting, kind of introduced by Dr. Albano, sports and rehabilitation with Dr. Yoakum. So Dr. Cox has said all of them. He will share all the latest in spine research. So please join us live at something soon or online. And of course, the Cox 8 table by Haven Medical is the one that we do all of our research on, measures forces, and you can come study those. So thank you for joining us today. If you have any questions, you can send them in. I don't see any in now, but your handouts are there. You can download those, and maybe another 2 to 3 weeks we'll do one of these. And otherwise, you have to go treat patients here, and it's 12:58. We did really well. You did good.
Yeah, thank you for studying.
Well, have a good afternoon.